The following podcast is part of a certified educational activity titled Managing Pulmonary Arterial Hypertension in the Era of Novel and Emerging Treatment Options. It takes a village. Access the entire activity and complete the post-test at peerview.com/MVM860. Downloadable slides and practice aids are also available.
Hello, and welcome to this activity on managing pulmonary arterial hypertension in the era of novel and emerging treatment options. I'm Aaron Waxman from the Brigham and Women's Hospital. Our goals for today are, 1, to help you distinguish the clinical manifestations of pulmonary arterial hypertension to facilitate early and accurate diagnosis. We want to be able to provide you with guidance to apply updated guidelines and criteria to diagnose pulmonary arterial hypertension, risk stratify, and monitor the disease state. We want to be able to enhance your ability to select treatment for patients with PAH, including the use of novel therapies with alternative mechanisms of action. And lastly, we hope to equip you with strategies for collaborating with the healthcare team to counsel patients and enhance shared decision-making. Early recognition of pulmonary arterial hypertension, the importance of an interprofessional approach. I think it's important as the field has advanced that we have really moved into a realm where this is a collaborative team effort. It involves a number of medical specialists and advanced practice providers. And this includes the evaluation and diagnosis of patients with pulmonary function testing, disease severity assessment monitoring, and patient education. Certainly from the cardiology standpoint, we think about evaluation and diagnosis, especially in regards to cardiac function monitoring, right heart catheterization to confirm the diagnosis, as well as risk stratification and patient education. Advanced practice providers play an important role in providing clinical care, especially in recognition of signs and symptoms, assisting with diagnosis and coordinating diagnostic testing, and I think equally important, educating and advocating for our patients. Recently, the European Society of Cardiology and the European Respiratory Society have updated the clinical classification system for pulmonary arterial hypertension, and this was further updated in the 7th World Symposium. I think the important findings here are in Group 1 disease. We think about idiopathic pulmonary arterial hypertension, and within that group, we think about non-responders at vasoreactivity testing and acute responders at vasoreactivity testing, which help us figure out how best to treat the patients. The rest of these have been left pretty much as they were from prior group categorizations, and you can see the breakdown here of heritable, drug-induced and toxin-induced PAH, and PAH associated with various underlying disease states, including connective tissue disease, HIV infection, portal hypertension, congenital heart diseases, and schistosomiasis. There's also the concern of PAH with overt features of venous and capillary involvement, such as pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis. And then lastly, the persistent pulmonary hypertension of the newborn. The definition of pulmonary hypertension has also been updated, and really it means lowering some of the pressure thresholds where we define disease, which means a greater number of patients may have this disease. We can think of it in terms of precapillary pulmonary hypertension, where the mean pulmonary artery pressure should be greater than 20 millimeters of mercury, and the pulmonary arterial wedge pressure being equal to or less than 15 millimeters of mercury. And most importantly, the pulmonary vascular resistance has been decreased from 3 Wood units down to 2 Wood units. We can also think in terms of isolated post-capillary pulmonary hypertension, where again, the mean pulmonary artery pressure is greater than 20, but this time the pulmonary arterial wedge pressure is greater than 15 millimeters of mercury, consistent with the pressure being driven from the left side of the heart. And here the pulmonary vascular resistance is in the normal range, equal to or less than 2 Wood units. And finally, we think about combined precapillary and postcapillary pulmonary hypertension, where there's been long-standing elevated pulmonary arterial wedge pressure greater than 15 with remodeling backwards through the pulmonary vascular bed, driving that mean pulmonary artery pressure up, but now also with evidence of pulmonary vascular remodeling, with the pulmonary vascular resistance being greater than 2 Wood units. And new to the definition is the inclusion of exercise pulmonary hypertension. And here the definition is based on the slope of the relationship between the mean pulmonary artery pressure and cardiac output. And the slope should be greater than 3 to define a exercise pH. And this is a dynamic slope in that as patients exercise and the mean pulmonary artery pressure goes up, looking at how that relates to the changes in cardiac output with exercise. This is based on the 7th World Symposium on pH, which essentially states exactly the same thing we just discussed from the ERS and ESC guidelines. So next we have to think about when should we be thinking about pulmonary hypertension in our patients. And there are a number of signs and symptoms that bring up concerns for pulmonary hypertension. Many of these signs and symptoms are not specific to PAH, but they should at least cause one to be thinking about the diagnosis within the full differential diagnosis. I think the most important symptom that we deal with is shortness of breath or dyspnea on exertion. And based on that, we can also define a WHO functional class. Patients may have very subtle signs and symptoms at presentation early in disease states, and then as the disease progresses, we may see even more obvious signs and symptoms. I think some of the more important things that happen late in disease include exertional chest pain that can sometimes be confused for coronary pain. There can be changes in speech, dysphonia, or hoarseness. This can be because the pulmonary artery gets enlarged and compresses the left recurrent laryngeal nerve. And also shortness of breath can be very limiting. It can be very obvious even at rest, and sometimes can cause compression of bronchi because of enlarged pulmonary arteries. Thinking more about some of the clinical signs and symptoms in patients with PAH, cyanosis can certainly happen if there are shunts involved, and certainly in congenital heart disease, we may hear abnormal sounds on examination of the right heart. There can be murmurs such as tricuspid regurgitation that may vary with respiratory efforts. There can also be diastolic murmurs if the pulmonary regurgitation is significant. Other things you might see are digital clubbing. These can happen in various disease states, especially in patients who are hypoxemic. We may hear various lung sounds and heart sounds depending on coincident disease states. We always have to be thinking about deep vein thrombosis or venous thromboemboli, and of course, chronic thromboembolic disease or chronic thromboembolic pulmonary hypertension. In our patients with connective tissue disease, we certainly need to think about telangiectasias, and when appropriate, even think about disease states like HHT. And we can see clinical changes in a number of different connective tissue diseases like sclerodactyly, Raynaud's, and digital ulcerations. All of those things do put patients at risk for pulmonary hypertension. Some of the signs we look for include distended or pulsating jugular veins when the pressure is high and driving backwards. There can be abdominal distension and even a fluid wave associated with that in those patients who may develop ascites. And we can see hepatomegaly. And of course, probably the more common of all of these would be peripheral edema. And as far as some other signs of right ventricular failure, there can be cyanosis, especially around the lips or in the fingers. Patients can complain of dizziness when they get up too quickly or when they're exerting themselves. They may have pallor. Their extremities may be cool because of poor circulation and poor perfusion. And with that, we may also see prolonged capillary refill. There are a number of challenges with diagnosing PAH. First of all, it's a rare disease, so clinical suspicion is often low. Also, a lot of the symptoms and signs, especially in early disease states, are nonspecific and often are thought of as related to other diseases. There may be some biomarkers drawn, like an NT-proBNP, that if elevated without another explanation, could certainly suggest pulmonary hypertension. Once you get into the expert realm, there are a number of tests that are often thought of right away, like the echo. The echo is an estimate of pressure. It is not a diagnostic test, and really should be thought of as a screening tool. And there are a lot of subtleties to the echo, especially in early disease. Pulmonary function testing often can be normal in early disease states, and that diffusing capacity may be an early marker with just a subtle decline, to make you think that it may not be an airway problem or a lung parenchymal problem. Cardiopulmonary exercise testing can certainly define a physiologic limit to one's ability to exercise. It's not going to provide a diagnosis, but if it's abnormal, it ought to at least trigger thinking about what is the next test. And at a specialist PH center, the fundamental test is going to be the right heart cath. It is the diagnostic gold standard and is really required before treatment can be considered. So this slide illustrates the diagnostic algorithm, which is currently part of the guidelines. And this is how we approach a patient with suspected pulmonary arterial hypertension. You can see a lot of testing is included on this stepwise approach, and it allows for judgment as to how much lung disease versus cardiac disease this patient may have. Regardless of what that patient's background, there are some basic tests that need to be done, including the pulmonary function test, some sort of imaging of the chest, and echocardiography. All of those tests then come together in the clinician's mindset and puts the patient into a risk for pulmonary hypertension. And based on that risk, you may decide on additional testing versus going straight to right heart catheterization. And I would suggest that anytime there is a concern for pulmonary hypertension, that really thinking about referral to a center at that point is a good idea, because many of the centers have a very strict way of how we do right heart catheterization, which fundamentally is the diagnostic test. So importantly, and as I've said previously, the echocardiogram is the fundamental screening tool when we are thinking about a diagnosis of pulmonary arterial hypertension. When we do an echo, one of the important measures is the tricuspid regurgitation velocity, and that is measured as a standard part of every echo. When we see that velocity 2.9 meters per second or greater, it increases the likelihood that the pulmonary artery pressure is elevated and really should push us in the direction of now thinking about right heart catheterization. There are some other subtle findings that we would look for on an echo, including right atrial dilation, right ventricular dilation, any changes in right ventricular function as measured by what's called the tricuspid annular plane systolic excursion, or TAPSE. We may see findings in the inferior vena cava that might clue us into an increased right atrial pressure. There we would see a dilation of the inferior vena cava or less mobility in the inferior vena cava. All of these things add into this stepwise approach of increasing the likelihood that a patient may have pulmonary hypertension, and would then direct us to right heart catheterization to confirm the diagnosis. The VQ scan is part of the workup once we've made a diagnosis of pulmonary hypertension. It is used to look for chronic thromboembolic pulmonary hypertension, and obviously this should never be missed because it's a potentially curable form of pulmonary hypertension by surgery. It can also be amenable to balloon angioplasty if it's more distal disease. Um, Most patients with CTEPH never complain of an acute event, so it's always an index of suspicion that's enhanced when we get imaging. And I will point out that CT angiogram, especially in the current state of the art, is often the first choice because it not only provides a diagnosis, but also can provide a roadmap for the surgeon or the interventionalist. The diagnosis of pulmonary arterial hypertension requires a right heart catheterization, and we would never start treatment before obtaining the hemodynamic assessment. The echo, as I said, is a screening tool, and it provides some index of what's going on in the heart. It helps us figure out, is there any left-sided heart disease? It also can help rule out any valvular heart disease. But the importance of the right heart cath is not only that it confirms the elevated pressure, but it also allows us to measure the pulmonary vascular resistance and measure cardiac output. It then provides information as to, is this precapillary, is it pre versus postcapillary, or is it isolated postcapillary disease? So it really confirms the diagnosis. It also establishes a level of severity and helps us give patients information on prognosis. And equally important, it allows us to do vasodilator testing, which also provides insight as far as how we might treat the patient. So who should we be screening for pulmonary arterial hypertension? There's certainly a number of patient populations that we advocate screening. BMPR2 mutation carriers, those patients who might be at risk for familial pulmonary arterial hypertension, any first degree relatives of patients with familiar or what it could be called heritable PAH. Patients with certain connective tissue diseases, especially systemic sclerosis, should be screened. And patients with portal hypertension, especially if they're being referred for liver transplantation, so that we can treat that PAH before they actually are faced with a surgical decision making. And then patients who are symptomatic with portal hypertension, HIV infection, or other forms of connective tissue disease other than systemic sclerosis. And again, the screening tool would be echocardiography. So once we have a diagnosis of pulmonary hypertension, there are a number of tools we use to put that patient into a risk category. There are some biomarkers, specifically the NT-proBNP. There are also a number of clinical assessments that we use, like functional class, how rapidly progressive the symptoms are there signs of right heart failure on exam, and importantly, has that patient had an episode of syncope? And that is a very concerning finding. Likewise, we can use exercise testing, including cardiopulmonary exercise testing with gas exchange or the 6-minute walk distance. The echocardiogram provides us a number of findings that can put that patient into a different risk category, such as the right atrial area or the presence of a pericardial effusion. And then there are some hemodynamic measures that can help us, including the right atrial pressure, which is clearly associated with prognosis, and then indices of cardiac function and pulmonary blood flow, like the cardiac index or the mixed venous oxygen saturation. There are a number of risk calculators that can be used to place patients into a risk category. This is the Reveal Light 2 calculator. And you can see here it makes use of all of those things we just touched on. And you simply plug it into the calculator, which is available online, and it will provide you a score that you can then categorize that patient into low risk, intermediate, or high risk. This is one of the European calculators using a 3-category risk, and it essentially uses the same indices that we just touched on from the Reveal. It includes cardiopulmonary exercise testing and BNP, in addition to some of the clinical criteria we just touched on. This is just some additional information on the European risk calculator, including some additional features such as the echo, cardiac MR, and hemodynamics. More recently, the Compara 2.0 risk score used a 4-stratum risk assessment model, looking at patients who were considered at low, intermediate, high, and high risk based on their long-term mortality. And using the 4-risk strata assessment tool, you can see here the components of that risk score that are used to place subjects into one of these 4 risk categories. This was felt to be a more accurate approach because of the increased number of categories. So now we'll talk about the use of novel agents in the treatment of PAH and where these new options fit into the treatment paradigm. There are a number of treatment goals in the management of the patient with pulmonary arterial hypertension. I think obviously we want to see improvement in survival and improvement in quality of life. I think one of the fundamental goals of treating patients is to see improvement in hemodynamics. And if we can improve hemodynamics, then we're likely to see an improvement in exercise tolerance, including a better 6-minute walk distance. And with that, we should see an improved functional classification, and all of that would translate to better quality of life and more likely improvement in survival. From just a day-to-day management, we want to see less severe symptoms. We want to prevent clinical worsening, and some of that may require titration or escalation of therapy. We want to limit hospitalizations, and we certainly want to avoid lung transplantation. And as we've already said, we want to prevent death and improve survival. This is the current guideline treatment algorithm, and it really comes down to a risk assessment, whether using your 3-strata or 4-strata risk, and using monotherapy only in those patients who might be at low risk, and then using more aggressive combination therapy, whether it be dual or triple combination therapy, again, depending on where that patient falls into the risk category. Intermediate low likely being acceptable to treat with dual combination, and anyone in the intermediate high or high risk category really being much more aggressively managed with at least triple therapy. And this, again, emphasizes the initial treatment strategy for those patients, depending on their risk score, so that patients who are in the more advanced risk categories should be treated more aggressively with multiple drugs, much the same way we would treat a patient with cancer or any advanced complicated disease. I think importantly, anytime we're talking about these complicated therapies, it's a shared decision-making approach. Patients ultimately have choices, and I think there's also the issue of what the clinician recommends and why they recommend. We have to take into consideration any comorbidities. We have to think about what other medications those patients might be on and any potential drug interactions. And then the other issue is how closely we follow those patients and make decisions in a longitudinal way. The patient obviously needs to be a partner in all of this, and their perspective on what's going on and what the future holds is critical. Patients often are experiencing a delay in diagnosis. They've often been shuttled between various physicians. It's not uncommon for patients to bounce between a pulmonologist and cardiologist trying to come up with a diagnosis, especially in the early phases of disease. This can set in obvious anxiety and fear of both the disease and the system. And ultimately, the right heart catheterization is going to be proposed, and that's an invasive procedure that also comes with some hesitation on patients' parts. So being able to allay those fears is critical. Management concerns, again, the overall quality of life of these patients is important. The impact of the disease and the treatments on day-to-day issues that the patient has to deal with, such as employment, education, the finances. All these drugs we use are very expensive. The social life issues, especially when we think about our patients who might have pumps and chronic infusion systems. And then we always have to think about their mental health because it's easy to get depressed when one has a chronic disease. So there's lots of need for accurate information and updated information, and making sure that patient has good access to care. And then we also have to be thinking about the traditional PAH parameters, the things that really brought that patient to us in the first place, their symptoms, their exercise tolerance, any biomarkers we want to be drawing, and of course, the hemodynamics and survival. It is very likely at this point that the treatment algorithm is going to be updated because there is now a fourth pathway available to treat patients who are considered at intermediate high and high risk, and that is the advent of the activin signaling inhibitor pathway. That will be an additional tool to take care of these patients, and I think needs to be considered in any patient who is still in intermediate high risk and high in spite of being on appropriate background therapy. So currently, we can now think of the treatments for PAH to fall into now four categories where we used to talk about three. Um, we've always talked about the endothelin pathway and the fact that patients with pulmonary hypertension have elevated levels of endothelin, which is a very potent vasoconstrictor and pro-fibrotic agent. We've also talked about the nitric oxide pathway, which includes the phosphodiesterase 5 inhibitors, as well as the soluble guanyl cyclase stimulators. All of those enhance the activity of nitric oxide, which is often decreased in patients with PAH and is our most important endogenous vasodilator. And lastly, the prostacyclin pathway has been the most important pathway up until now and is reflective of the decreased availability of circulating prostacyclin in our patients with PAH, which itself is a very important vasodilator. We can now add a fourth pathway, the Activin TGF beta signaling pathway, with the new class of drugs, the Activin signaling inhibitors, which serve to rebalance the pro-proliferative, anti-proliferative milieu that is abnormal in our patients with PAH. So, thinking about the data behind the idea of combination therapy, this was probably one of the more important studies early on. This was the Ambition trial that looked at upfront dual combination therapy with an ERA called ambrisentan and a PD5 tadalafil versus monotherapy. And for the first time, this showed a marked improvement in our patients' long-term outcomes, both survival, time to clinical worsening, and functional class and exercise tolerance in those patients who received upfront dual combination therapy. A new agent to come along is a combination of macitentan and tadalafil in a single tablet combination. This is taking the same approach as Ambition, but with a different ERA, and simply makes our patients' lives easier in that they only have to take one pill rather than three pills. The indications for using this combination therapy are chronic treatment of PAH, specifically WHO Group 1 in adults who have WHO functional class 2 or 3, and individually macitentan, which is an endothelin receptor antagonist, reduces the risk of clinical worsening events and hospitalization, and tadalafil, a phosphodiesterase 5 inhibitor, improves exercise ability. Some of the complications we need to be aware of so that we can help our patients tolerate these drugs. The endothelin receptor antagonists, all of them are teratogenic. So if a patient should get pregnant, they need to stop these drugs. But more importantly, they should be counseled to not become pregnant while on these meds. Prostacyclins have a number of side effects, also those that are provided by a continuous infusion. There's always a risk of central line infection. We also worry about abrupt discontinuation of prostacyclins and the possibility of rebound pulmonary hypertension. For the PD5 inhibitors and soluble guanyl cyclase stimulators, sildenafil should not be used with nitrates or in combination with the guanyl cyclase stimulator because patients can develop pretty significant hypotension. Same thing can be said for tadalafil, which obviously is a long-acting PD5 inhibitor. And riociguat, which is a soluble guanyl cyclase stimulator, should not be used in combination with nitrates or sildenafil or tadalafil. And also is a drug that requires titration when it's started and continued. Now, importantly, the Bourne morphogenetic protein receptor 2 was recognized as an important component of pulmonary arterial hypertension now more than 25 years ago. This was initially discovered in familial disease, and now we've recognized that downregulation of BMPR2 occurs in all forms of pulmonary arterial hypertension. BMPR2 signaling is now a target of therapy with the Activin signaling inhibitors. Remember, BMPR2 signaling is downregulated in patients with PAH, which allows for a pro-proliferative anti-apoptotic milieu that drives pulmonary vascular remodeling. Activin signaling inhibitors bind activin and growth differentiating factors, which allow for a rebalancing of the BMPR2 signaling pathway so that pro-proliferative and anti-proliferative signaling now become more normal and allow for reverse remodeling of the pulmonary vascular bed. Sotatercept represents the first in class of the activin inhibitors. It is a novel fusion protein that binds activins and growth differentiating factors. And as you can see in this picture on the right, by binding these activins and growth differentiating factors, it essentially traps these ligands and reduces the pro-proliferative signaling that is abnormal in pulmonary arterial hypertension. By binding these mediators, it serves to rebalance the pro-proliferative with the anti-proliferative signaling and allow for a more normal milieu of homeostasis in the pulmonary vascular bed. This then allows for reverse remodeling of the pulmonary vascular bed and a normalization over the long course of right heart function. The use of sotatercept came after the STELLAR phase 3 clinical trial. This was a randomized, double-blind, placebo-controlled, multi-center parallel group study and evaluated the efficacy of sotatercept on top of background therapy in patients with pulmonary arterial hypertension who were functional class 2 or 3 in spite of appropriate background therapy. This was a 24-week trial, and you can see how it was designed here. Patients had to be group 1 PAH. They had to be functional class 2 or 3. This was an adult study. You can see the hemodynamics there. PVR was actually quite high at greater than 400 dynes, and they had to have a normal left atrial pressure or pulmonary capillary wedge pressure being equal to or less than 15. The 6-minute walk distance was 150 to 500 meters. And as stated, they had to be on stable background therapy. Patients were randomized 1-to-1. They started at a dose of 0.3 milligram per kilogram. This drug is delivered as a sub-Q injection every 3 weeks. And after the first month, all patients were increased up to 0.7 milligrams per kilogram. And the outcome measures you can see on the right of this panel. The primary outcome was improvement in 6-minute walk distance. Secondary endpoints, including a multi-component clinical improvement, which was a 3 components. It required a better than 30-meter improvement in 6-minute walk distance, a better than 30% improvement in the NT-proBNP, and an improvement in functional class. And to hit that endpoint, you had to actually hit all 3 of those components. Those components were also considered individually, and then we also looked at time to clinical worsening or death, and also the French risk score, as well as a number of quality measures. This was the primary outcome, which showed a very statistically significant improvement in 6-minute walk distance when sotatercept was added on to background therapy. This shows you the time to clinical worsening or death. The upper blue line are those patients who were treated with sotatercept versus the orange line, those patients treated with placebo. And you can see there was a highly significant improvement in the delay of clinical worsening and death. These are some of the endpoints broken out individually. You can see on the first line there, the multi-component improvement again, highly significant. And then the reduction in pulmonary vascular resistance and the reduction in the NT-proBNP, all statistically significant improvements. As far as the tolerability of this drug, it was fairly well balanced between sotatercept and placebo. Uh, you can see the number of adverse events there. And then, as far as that leading to discontinuation or withdrawal from a study, were actually quite low in the sotatercept group. These are some of the treatment emergent adverse events. Probably the most important are the bleeding events. These are likely related to the development of telangiectasias in the patients who received sotatercept. Probably the most important bleeds were nosebleeds and some GI bleeds. There are a number of ongoing studies with sotatercept. There is a pediatric study right now in children under 18. There are a number of adult studies still ongoing. Soteria is the long-term open label extension. Hyperion and Zenith are looking at patients who are newly diagnosed or those who have a high risk category, respectively. And then there is an ongoing study called Cadence, which is looking at patients with combined pre and post capillary pulmonary hypertension. There are some other drug studies ongoing, especially targeting the Activin receptor inhibitor pathway. You can see the top two here are still in phase 2 and phase 1 study. There's also a number of other trials ongoing, one looking at ralinepag, which is a prostanoid IP receptor antagonist. And then there's the seralutinib study, which is a PDGF, a platelet-derived growth factor a signaling inhibitor, which is now undergoing phase 3 study. So I think it's often easier to run through how we manage these patients by thinking about a case. Marie is a 33-year-old woman who presented as a gravid 2, para 1. She had a 5-year-old healthy child. She had had one spontaneous abortion and has a history of Raynaud's. She presented with a 3-year history of dyspnea on exertion, which had been more rapidly progressive over the 6 months prior to presentation. Because of her shortness of breath, she had been treated for asthma with a long-acting beta agonist and inhaled corticosteroid, which never really helped her breathing. Importantly, she also never had pulmonary function testing done to document a diagnosis of asthma. She was even treated with multiple steroid tapers without any benefit. 1 month prior to her presentation, she had had a preoperative chest x-ray. She was going to undergo a gynecologic procedure, and that chest x-ray suggested enlargement of the pulmonary arteries, and that triggered the referral for evaluation. When she finally did present, she was very symptomatic, having trouble climbing a flight of stairs or any inclines. You can see her past medical history here, notable for Raynaud's, and I throw that asthma in quotes because it's really questionable. She has no significant family history. Social history, pretty unremarkable. She's on no medications. She had actually stopped her inhalers because they weren't helping her. You can see her physical exam findings on the right. She's a little tachycardic, mildly reduced blood pressure, and her oxygen saturations are on the low side, which I think is important to recognize is not typical of asthma. No jugular venous dissension. She had some soft rales at the bases that generally cleared with a big inhalation. Cardiac sounds were unremarkable, and she did have 2+ lower extremity edema. This was her EKG at the time of presentation. Obviously, you can't make a diagnosis of pulmonary hypertension with something like this, but it does have some subtle findings in here, such as a right axis deviation and right atrial enlargement. We did do pulmonary function testing on this patient, and it turned out her spirometry and lung volumes were perfectly normal, but her DLCO was subtly low, even though everything else was glaringly normal. She had a normal metabolic panel. Her liver functions were normal. Blood counts and thyroid function were normal. You can see her NT-proBNP was elevated. We often draw that so that we can plug it into a risk calculator. And her ANA was mildly increased as well. She did not have any clinical stigmata to suggest a specific connective tissue disease. And we often see an elevated ANA in pulmonary hypertension. This is her chest x-ray, and what I'm showing you here with the black arrows are the enlarged pulmonary arteries, and the white arrow is showing you some vascular pruning as those vessels head out to the periphery. The CT scan on the left is showing an example of mosaic attenuation that is a subtle finding that we often see in PAH, and the panel on the right is a CT angiogram that shows no evidence of chronic thromboembolic disease. This is the patient's ventilation perfusion study, which does not show evidence of chronic thromboembolic disease. What you can see on the left is the perfusion images. Kind of has a little bit of a moth-eaten appearance to it, which is typical of pulmonary vascular involvement. And on the right are the ventilation images, which are perfectly normal. We did a 6-minute walk distance on the patient. She walked about 318 meters. A patient this old, otherwise healthy, should be able to walk close to 600 meters. So this is quite impaired. Borg scale is a 1 to 10 scale of shortness of breath, and Borg of 5 is someone who is complaining of significant shortness of breath with exertion. And here too, you can see she desaturates to 89%, which again is not typical of a patient with asthma. Her CT scan, as shown, showed no signs of interstitial lung disease or pulmonary emboli. The VQ scan did not show evidence of large obstructive clot, and we saw the EKG that showed a right axis deviation and findings of right ventricular hypertrophy and P pulmonale. Her echocardiogram was then done as a screening tool, and what we saw, which is shown and illustrated on these images, on the left is the 4-chamber view that shows both right atrial and right ventricular dilation, and on the right is a short axis view showing enlarged right ventricle with septal flattening and a D shape of the left ventricle. If you look closely, there's also a subtle pericardial effusion. This is showing you the tricuspid regurgitation jet on the left and the measurement of the velocity of that TR jet on the right. This velocity can then be plugged into the modified Bernoulli's equation, and we can estimate the right ventricular systolic pressure. Remember that any time that jet is greater than 2.9 meters per second, that's a good indication that there may be elevation of that pressure, and we ought to be thinking about doing a right heart catheterization. In this case, you can see that the right ventricular systolic pressure is around 78 millimeters of mercury, estimated based on that TR jet. We then take the patient to the cath lab, and these are her findings on right heart catheterization. You can see the right atrial pressure is markedly increased at 17 millimeters of mercury. Normal should be around 12 or less. You can see the right ventricular pressure here is almost systemic with a systolic pressure of 87, a diastolic of 12, and an end diastolic of 21 millimeters of mercury, which is quite elevated and suggestive of how stretched that right ventricle is. Normal should be about 12 or less. You can see the pulmonary artery pressure there is very significantly increased at a mean of 54, and again, normal is 20 or less. And there's the pulmonary capillary wedge pressure of 14. And then the cardiac output, you can see, is preserved with an index of 1.8, which is mildly reduced. And most importantly, there is the pulmonary vascular resistance of 710 dynes, which we can convert dynes to Wood units by dividing by 80. And there you can see she has a PVR of 9 Wood units. And remember that 2 is the upper limit of normal. We did do vasodilator testing with nitric oxide, and she did not meet guideline requirement for vasoresponsiveness. so she would not be a candidate for calcium channel blockers. So to review, based on her history, she was a New York Heart Functional Class 3B. There's her physical findings, her 6-minute walk distance, and NT-proBNP. We plug all of that into a risk calculator, and her REVEAL score was greater than 8, which puts her into a high-risk category. So now the issue is, how do we treat this patient, and how would we monitor her and follow up? Based on her risk score and her functional class, we elected to start this patient on intravenous treprostinil. Within about 2 weeks, we added on oral tadalafil. She was already starting to show improvement, and 2 weeks after that, we added ambrisentan. So you can see that we treated her with upfront triple combination therapy. We repeated an echo 6 months later that showed some improvement in her IV size and function. The estimated pressure had not really changed, which is not surprising, but you can see that her 6-minute walk distance improved dramatically. Her Borg scale came down significantly, and her functional class has started to improve. And we show you now the echo on the left, were the echoes that we showed you earlier that showed findings concerning for pulmonary hypertension, and the echoes on the right show pretty much normal size and function of the right heart. This patient actually elected to go into the SPECTRA study, a sotatercept open label study, and now you can see where she is 2.5 years later. Her treprostinil dose is now at 66 nanogram per kilo per minute. She continues on ambrisentan 10 daily and tadalafil 40 milligrams daily. And with the addition of sotatercept, you can see that she has normalized her hemodynamics on right heart catheterization, and she's also normalized her functional class, now functional class 1. So to summarize then, early recognition of pulmonary arterial hypertension is critical to improve outcomes, and it requires a comprehensive assessment including pulmonary function testing, echocardiography, and right heart catheterization. There are a number of validated risk calculators that can help us risk stratify our patients, which can then be used to guide not only prognosis, but importantly, therapy. The goals of treating a patient with pulmonary arterial hypertension include improving survival, improved quality of life, improving exercise tolerance and capacity, improving hemodynamics, and to limit any clinical worsening. Conventional treatments address predominantly vasodilation and can be complicated because they require titration, and the use of them in combination can cause some side effects. In spite of that, they have improved our patients' long-term outcomes. I think advanced treatments with agents that have alternative mechanisms are now showing us that we can really improve how patients feel, function, and survive. Diagnosing and managing patients with PAH optimally requires an interprofessional approach using shared decision-making such that that patient is an integral part of the team. That concludes our program. Thank you so much for joining me today, and I hope you find this activity to be useful to your practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Merck Co, Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/MVM860.